The topic for today is undesirable and altered immunity. Normally, in the presence of an antigen, the body should be able to eliminate that antigen without causing any damage to the tissue host. However, there can be some deleterious effect that may result in tissue damage and it can actually be fatal. The term for this is called hypersensitivity or allergy. Although the word uses hypersensitivity, that implies that there is an increased response. It's not always heightened, but sometimes it's just only inappropriate response to an antigen. This can be either humoral or cell-mediated immune response, and the only requirement here is that the hosts should be pre-sensitized or exposed to the substance. There are four different types of hypersensitivity reaction. So we label them with Roman letters 1, 2, 3, and 4. The first one is anaphylactic, then cytotoxic, then immune complex, and the last one is cell-mediated reaction. The first three are antibody or antigen antibody complex mediated, while the last one is cell mediated. This is also known as delayed type hypersensitivity reaction. Type 1 or anaphylactic reactions is also known as immediate hypersensitivity for obvious reason because it can develop within 15 to 30 minutes after exposure to the allergen. This is mediated by IgE, and the primary component is the mast cell or the basophil. The mechanism of reaction involves the production of immunoglobulin E. In this slide, we can see the mechanism of type 1 hypersensitivity reaction. So the presence of the allergen binds to the surface of the B cell, and in turn the B cell can interact with the TH2 cell through the CD4 membrane receptor and through the interleukin 4. This can cause the formation of memory cells and plasma cells. Plasma cells can produce the antibody, which is primarily IgE, and it can bind with mast cells that can degranulate to release different mediators of allergy. So if you remember, there are vasoactive amines. Among the most prominent is histamine. So it will have an effect on different cells and tissues of the body. We can see in this table the different mediators of hypersensitivity, type 1 hypersensitivity, and the effects of those mediators. For example, histamine, heparin, and serotonin can cause increased vascular permeability, leading to more blood going to the part that is affected. And that means it can be red in color. And the smooth cell muscle cell contraction leading to maybe in the case of the bronchial cells, it can cause difficulty of breathing. Eosinophil chemotactic factor, neutrophil chemotactic factor. So it's obvious that the effect is chemotaxis, the migration of the WBC in the site of allergy. And proteases, which can cleave proteins. For example, one effect is bronchial mucosecretion. So that will make the reaction even worse when there is difficulty of breathing. And so other results like formation of blood vessel basement membrane degradation and complement split products. For the secondary effects, it can also trigger other substances indirectly, like PAF, platelet activating factor. So it can trigger the platelet to aggregate and degranulate. Okay, so what do you think will happen when these platelets are triggered? There may be coagulation, disseminated intravascular coagulation, and secondarily contraction of the pulmonary smooth muscles. Leukotrienes like SRS-A, right? So that means low reactive substance of anaphylaxis, increased vascular permeability, contraction of pulmonary smooth muscles. We mentioned that also in relation to other substances. Bradykinins, so it can cause again increased vascular permeability, smooth muscle contraction. Prostaglandins cause vasodilation, the same effect, and contraction of the pulmonary muscles and platelet aggregation. And cytokine productions leading to systemic anaphylaxis. Right, so this systemic anaphylaxis is a fatal state. It's a shock-like and fatal state that can happen within minutes after a hypersensitivity reaction, type 1 hypersensitivity reaction. This may be due to some substances, for example, venom coming from certain insects like bees or wasps or hornet or even ants, bite or sting coming from those insects. And then drugs like penicillin, insulin, and antitoxins, and even food like seafoods and nuts. The requirement here would be to treat immediately, otherwise it would be fatal. And the drug of choice is epinephrine. There is also localized anaphylaxis. So most of the time, this is limited to a specific tissue or organ. Most of the time, this is the epithelial cell of that organ. So it can be the skin or it can be the respiratory tract. So this is inherited. So when it is inherited, we call it atopy or atopic. So examples of these would be allergic rhinitis or hay fever, asthma, atopic dermatitis or eczema, or skin asthma, and food allergies. Allergic rhinitis is usually caused by airborne allergens that can sensitize the mast cells in the conjunctivae. So that's the eyes and the nasal mucosa, leading to sneezing, coughing, and crying. Another condition is asthma, which can be triggered by a lot of things like airborne substances like pollen, dust, fumes, and venoms, insect venoms, viral antigens. It can also be caused by exercise or the environment, very cold environment. This can affect the lower respiratory tract, leading to bronchoconstriction, and there may be edema in the airway. So this may block the passageway, mucus secretion, inflammation. So there may be difficulty of breathing. Next is atopic dermatitis. So this is a condition usually genetic in nature, affecting very young patients, children, and infants. It's starting from around 1 year old. So this condition is characterized by the presence of red skin eruptions, erythematous, and filled with pus. This is caused by Th cells associated with an increased number of eosinophils. Okay, compared to delayed type hypersensitivity reaction, which is caused by Th1 cells. Next is food allergies that can be caused by the allergen. For example, seafood, which contains iodine, can cross-link with the IgE in the mast cells, and it can trigger the contraction of the smooth muscles of the lining of the GI tract, and also vasodilation leading to symptoms like vomiting or diarrhea. So the muscles can degranulate, releasing the mediators, okay, and the allergen can enter the bloodstream. This can cause many other symptoms like asthma or atopic urticaria or hives. Hives is in Filipino, pantal, right? So we have here some examples of allergens. So they can be protein, foreign serum, something that is introduced to your body, like vaccines, right? So plant pollens, like ryegrass, ragweed, timothy grass, birch trees. So we usually experience this when if in a particular season, for example, spring, when there are so many flowers releasing their pollens. Drugs like penicillin, sulfonamides, anesthetics, salicylates, so aspirin, foods like nuts, seafoods, shrimps, crustaceans in general, eggs, and chicken, peas, beans, milk, so they all contain proteins. And then insect products like bee venom, wasp venom, ant venom, the cockroach calyx, dust mites, mold spores, and animal hair and dander. Right, so you would remember that if a person has asthma, sometimes they advise not to have cats or dogs in the house because they often shed their hair that can trigger an allergic response. How do we know if a person has allergy? One is we can do skin testing, then secondly we can do determination of serum level of total IgE antibody. For skin testing, we can do this simply by intradermal injection or scratching superficially the skin. So number of tests, so that means multiple allergens can be introduced on the certain site of the body, like the forearm or the back at one time. If a person is allergic to certain allergen, there will be flaring or the presence of wheal within 30 minutes. The advantage of doing skin testing is that it is inexpensive, it's easy to do, it allows a screening of many different allergens at one time. However, by introducing many of these allergens, the person may become sensitized to new allergens and it can lead to systemic anaphylactic shock. And sometimes the manifestation of this reaction can be delayed for up to 4 to 6 hours, even up to 24 hours. In this slide, we can see the arm of a person who was injected with different allergens, and you can see that there is a wheal formation on the grass area, but negative for the rest. So that means he is allergic to grass, but not allergic to the other substances. The total IgE antibody can be detected using RIST and RAST. So it means radioimmunosorbent test or radioallergosorbent test, RAST. Right, radioimmunosorbent test is highly sensitive. That is based on radioimmunoassay, and it can detect the level of total serum IgE, while RAST can detect the serum level of IgE for a specific antigen. So one is total, one is specific. Let us now move on to the second type of hypersensitivity, type 2, or cytotoxic reaction. This is mediated by antibodies, IgM or IgG, and the complement. It takes about a few minutes to hours for the allergy to happen. It can affect many different organs and tissues, and this can be endogenous, so that is already inside the body, or it can be triggered by chemicals outside the body, like haptens. So this is showing us the mechanisms by which the type 2 reactions happen. So as we have been told, it's triggered by the presence of antibody, and this antibody may already be present in the cells, attached to the cells. It can attract the complement leading to lysis. It can also attract cells that can lead to cell-mediated lysis. And thirdly, it can coat the surface of the cell that can serve as opsonin that attracts phagocytes. Right, so some examples of type 2 hypersensitivity reactions are transfusion reactions, hemolytic disease of the newborn, and drug-induced hemolytic anemia. The first one, transfusion reaction, is when the person is given incompatible blood. For example, in ABO blood group system, we know that the type of antibody is IgM, and this blood that was given to the person can trigger the production of another antibody, which is IgG in nature. So this is immune type of antibody. So that can, when this happens, the blood that was transfused to the recipient will be destroyed because of the presence of antibody and the complement. Next, hemolytic disease of the newborn. So this is when there is incompatibility between the mother and the baby. If the mother is Rh negative and gives birth to an Rh positive baby during the first pregnancy, there should not be any problem. However, the baby's blood may have sensitized the mother's blood to produce antibody against the Rh antigen. So this is anti-Rh, and this is IgG in nature, which can pass through the placenta. So during subsequent pregnancies, the second, third, and so on, there will be a destruction of the fetal red cells. The third one is drug-induced hemolytic anemia. When a person is allergic to certain antibiotics like penicillin, cephalosporin, or streptomycin, these antibiotics can adsorb non-specifically to proteins on the RBC membrane. So this can form a complex that is similar to a hapten carrier complex, and this can trigger the production of antibodies. The antibodies will attack the red blood cell, leading to lysis, complement-mediated lysis, and it may proceed to anemia. So this topic, hemolytic disease of the newborn, HDN, or erythroblastosis fetalis, is also taken up in blood banking, so I'm not going to talk much about this, except that the IgG that coats the fetal red cells can be detected using Coombs test. Immune complexes are formed when a number of antigens bind to an antibody. The antibodies that usually bind here are either IgG or IgM, and it's difficult for the phagocytes to recognize these small complexes. Then it leads to tissue damage. Some examples of antigens that can do this kind of damage are bacteria, viral antigens, parasitic infections, or even anti-nuclear antibodies that are formed against the nucleus of certain cells in case of systemic lupus erythematosus or SLE. When complexes are deposited in the tissue, especially in the site of entry, we call this reaction Arthur's reaction. When the complex is formed in the blood, so complexes again are deposited, and we call this serum sickness. Right, so serum sickness complexes are deposited on the walls of the blood vessels, in the synovial membrane of joints, in the kidneys, the glomerular basement membrane, and in the choroid plexus of the brain. The presence of these complexes deposited during serum sickness can lead to other conditions like SLE, RA, rheumatoid arthritis, and good posture syndrome. Moreover, we have more examples here like drug reactions. So if it's not the red blood cell that forms a complex with, it can lead to drug reactions, like in cases of penicillins and sulfonamides, in the development of complexes in infectious diseases like streptococcus infection. If you remember, if a person always have develop these sore throat, so that person may later develop heart disease, okay, involving the valves of the heart, right? Moreover, it can also attack the kidneys. So that is post-strep sequelae. Meningitis, hepatitis, mononucleosis, malaria, typhus. So we can name a lot of many different infectious diseases that can form complexes. Right, so the deposition of these complexes can initiate a reaction resulting in recruitment of neutrophils on the site, leading to tissue damage. In this slide, we can see the so-called Arthur's reaction. So if you remember, in Arthur's reaction, aside from the blood and any other tissue, if the antigen is introduced, the allergen is introduced, complexes can be formed. When you say complex, it doesn't limit itself to antigen-antibody complex, but for example, in this case, it can be a complex formed from complements, component of the complement. So this complement can trigger, it can trigger the production of mast cells to release, also to release their component, and this can cause the allergic reaction. For example, if it targets the blood vessel wall, there will be increased vascular permeability and the migration of the blood cells. Type 4 cell-mediated reaction. The first person who observed this kind of reaction was Robert Koch. So what he did was when he injected a Mycobacterium culture filtrate to the skin of a person, this person developed some kind of induration on the site of infection. And he called this tuberculin reaction. So this became the basis for type 4 hypersensitivity reaction. This type of reaction is dangerous because it can cause extensive tissue damage. However, most of the time it's limited. The tissue damage is limited. What else? The hallmark of type 4 reactions are delay in time required for the reaction to develop and recruitment of macrophages as opposed to neutrophils as found in type 3 reactions. So take note of that difference. In this case, the macrophages are invited rather than the neutrophils. The macrophages are the major component of the infiltrate that surrounds the site of inflammation. We can see here some examples of antigens that can lead to type 4 reaction. So bacteria like Mycobacterium TB, leprae, Listeria monocytogenes, and Brucella abortus. Fungi like Pneumocystis carinii, Candida albicans, Histoplasma capsulatum, Cryptococcus neoformans. I hope you still remember them in myco bacteriology. Intracellular parasites like Leishmania and viruses like herpes simplex virus, HSV, variola, and measles. Right, so some substances like perchloride chloride, so maybe you may have encountered this in the laboratory, hair dyes, nickel salts, poison ivy, so these are plants, and poison oak. So if you come into contact with these substances, there may be delayed type of hypersensitivity. Just last week, my cousin was telling me that she had this delayed type of hypersensitivity when she had been given the booster dose against COVID-19. Oh, anyway, so what are the phases of delayed type hypersensitivity? The first phase is called sensitization phase. So this is the time when the antigen and the host get into contact. So this takes about 1 to 2 weeks, and during this period, the T helper cells are activated and clonally expanded. So there is multiplication of the T helper cells and production of antigens, which is presented with the class 2 MHC molecule and the appropriate antigen presenting cells. So as we mentioned, this is the macrophages. Right, so some examples of this would be the Langerhans cells if it's the skin, and maybe other macrophages. Right, so T cells are activated during this phase and mostly are CD4 positive or Th1 subtype. The second phase is called the effector phase, so please correct the spelling. This is when the person is exposed to the same antigen. So this will lead to this phase. The effector phase is when the Th1 cells secrete a variety of cytokines that would recruit more macrophages and other non-specific inflammatory cells, and the response would take about 24 hours after the second contact, but it can extend to 48 to 72 hours. So the reason why there is a delay is because of there is a need for time for the cytokines to induce local influxes of the macrophages and their activation. So it takes time. The response is important in the host defense against parasites and bacteria that may be present inside the cells. Intracellular, that's why you mentioned of the word intracellular, wherein circulating antibodies cannot really find those antigens. So the pathogen is cleared rapidly with little tissue damage. However, in some cases, the antigen can also be not cleared, okay, therefore prolonged. So the response itself can be destructive to the host because of the intense inflammation that happens during the uh, reaction. So we can see here a diagram of the two phases. The sensitization phase is when the antigen, which is present in the macrophages, is presented to the Th1 cell. And then what will happen is that they will just, process those antigens. Next, on the second phase, the effector phase, this is the time when the sensitized or the exposed Th1 cells will produce cytokines that will invite the macrophages and get them activated. So that is the two stages or two phases of the DTH response. Some examples of cell-mediated reactions are tuberculin hypersensitivity and contact dermatitis. When we say contact dermatitis, so when you are exposed to, you touch like substances that may be present in cosmetics, hair dyes, so those that you apply on your body, or maybe they contaminated some household items or cabinets with formaldehyde, trinitrophenol, or nickel turpentine. Right. So what else? So that is why, for example, if you're going to buy a cosmetic product, something that you apply on your skin, or even the hair dye, they would advise you to test it on your skin first. That's in order to check for possibility of cell-mediated reactions. When a person is exposed to certain plants, for example, poison oak, poison ivy, or poison sumac, so they release a certain chemical. In the case of poison oak, it's pentadecacatechol. So this substance can pass through the skin and can be detected by the macrophages of the skin, the Langerhans cells. This is presented to the Th1 cells, which in turn can produce certain cytokines, interferon gamma, MCP1, MIF, right? So, and this can activate macrophages. The macrophages can then form lytic enzymes, and the damage caused to the tissue is because of these lytic enzymes. Right, so by doing an intradermal test, it is possible to detect if a person is already sensitized with the antigen or with the allergen. So a positive test means that the Th1 cells are already sensitized for the allergen. An example of this is when people are injected with PPD, which is purified protein derivative from MTB, in order to know if the person has been exposed to TB. Right, so the development of redness, swelling, and lesion on the site indicates that you are exposed. We are being exposed within 48 to 72 hours of the test. Right, so what is the significance of this? What we know is that the Philippines is known as a country that is exposed to TB. So in that case, my friend who went to Canada, she told me that they even tested her for tuberculin, and of course she will be tested positive for this because she comes from the Philippines. So we have some tests that we can perform, right? So in vivo or in vitro. In vivo, so that is when you do this onto the body, inside or outside the body, right? So delayed cutaneous reaction like MAN2 test, it should be a MAN2 test. Okay, patch test for contact dermatitis, and in vitro test, mitogenic response, lymphocytotoxicity. These are a little advanced tests, interleukin 2 production. So to summarize, there are four different types of um, hypersensitivity reaction: type 1, 2, and 3, and 4. Type 1 is immediate hypersensitivity mediated by IgE that triggers the uh, mast cells when they are bound to the antigen to release the content of the mast cells in the basophils. Some examples of these would be asthma, hives, food allergies, and eczema. Type 2 is cytotoxic, mediated by immunoglobulin G, and this is when the antibodies are directed against the cell surface antigens. So this leads to the destruction of those cells, okay, by the activation of the complement. So some examples of these are HDN and autoimmune hemolytic anemia. Type 3 is immune complex mediated. So this immune complex is deposited in the tissues that activates the neutrophils and other inflammatory cells. So the manifestation of this would be called the Arthur's reaction or serum sickness and some other secondary diseases. Type 4 is cell-mediated hypersensitivity. This is when the T helper cells, type 1, release the cytokines after sensitization, so the effector phase. So this can lead to contact dermatitis. Examples would be contact dermatitis or some tubercular lesions. Okay, so skin testing, okay, and also rejection of graft. Right. The second half of this presentation is about immunologic tolerance and autoimmunity. If you remember, lymphocytes, especially the T lymphocytes, are selected based on positive and negative selection. However, not all of them are deleted, especially those that are supposed to be deleted. And therefore, normal individuals, healthy individuals, may contain these mature, recirculating, self-reactive lymphocytes. The presence of those lymphocytes do not result in autoimmune reactions. So that means it will not really cause them autoimmune disease. Their activity, however, must be regulated. So there will be clonal suppression. So they will not multiply. A breakdown in the regulation can lead to the activation of the clones of these cells that will generate humoral and cell-mediated response against your own antigens. That's the problem. If this happens, there will be serious damage to the cells or organs with fatal, sometimes with fatal consequence. So this is what we call autoimmune response or autoimmune disease. Right. So normally when a person is exposed to the antigen for the first time, the second time the body meets the same antigen, there should be a response. However, if there is no response, even if you meet the same antigen, that is what we call tolerance. So when you don't react, when the immune system do not react with the presence of these antigen, or we call that substance a tolerogen. So tolerance is not the same as not a specific immunosuppression or immunodeficiency. It's like the cells, the B cells, the T cells are actually ignoring the presence of the antigen, right? So that is tolerance. It's tolerating the presence of that antigen. So the next concept is autoimmunity. This is when there is a response on the part of the immune system towards the self. So there is a breakdown in regulation and it permits the activation of self-reactive clones instead of, removing those clones that are acting against the self, they will be activated, right? So the T cells and the B cells, and it will result in organ-specific autoimmune disease or even systemic autoimmune disease. The organ function may be stimulated or blocked by the autoantibodies. So those autoantibodies are produced in this situation. If there is an antigen-specific immune response against an organ or a gland, it may result in direct cellular damage secondary to lymphocytes or antibodies that bind to the cell membrane antigens. So it can lead to cell lysis, inflammation, cellular structures that get replaced with connective tissues, or maybe the function can decrease or even stimulated or even blocked. So there are many possibilities on the part of the organ affected. Right, so we have here actually many examples of autoimmune diseases that are organ specific. For example, Addison's disease affects the adrenal cells, autoimmune hemolytic anemia, usually the RBC membrane proteins, good pasture syndrome, the renal and lung basement membranes, and so on. So please try to consider remembering the different organs or tissues that are affected by the different autoantibodies in certain diseases. Right. So this can also be systemic, as we have said. Aside from organ specific, it can affect the whole body. So It's widespread and it involves the formation of immune complexes, not just autoantibodies. Example here, ankylosing spondylitis affecting the vertebrae, multiple sclerosis affecting the brain or the white matter. Most of the time we say that this affects the um, covering of the myelinated nerve cells. So myelin, demyelinization. Rheumatoid arthritis, so if it affects the connective tissues and the IgG. Scleroderma, nuclei, heart, lungs, gastrointestinal tract, kidneys. Sjogren's syndrome, salivary gland, liver, kidney, thyroid, and SLE, the DNA, nuclear protein, RBC, and platelet membrane. So you can check more or less the one that causes this problem. So for the diagnosis, there are general tests and there are also specific tests. So one general test, C-reactive protein. So this detects inflammation in general, and antibody titers, specific antibody titers. The presence of RF, rheumatoid factor, is also a screening test. Now for specific tests, neurological examination, for example in MS, because there will be a problem with the uh, cognitive function of the person. Right. Fasting glucose can also be used to detect for diabetes, which is a type of autoimmune disease. Right. So measurement of TSH, thyroglobulin, for thyroid problems. Okay, so that would be the last slide for this autoimmunity. Third part, immunodeficiency. Immunodeficiency is when the immune system fails to provide protection, which can result in diseases, morbidity, or even death, mortality. So any part of the immune system can actually be deficient. For example, there will be lacking of cells or certain protein substances signaling mechanisms. So the body becomes susceptible to infection by organisms that normally don't cause diseases without resistance. So in some cases, homeostatic systems in the body will be disrupted and the severity is not the same all the time. Okay, it can also be primary or secondary. So the difference between primary and secondary. Primary is when there is a genetic defect that leads to problem in the development of the immune cells or their functions or the development or production of certain molecule. Right, secondary is because of certain factors, secondary factors or environmental factors like infection, malignancy, aging, starvation, medication, or drugs. So those are the possible causes of secondary immune deficiency. Right, so primary immune deficiency, these are the in yellow. So those are the problems or in the gray. So reticular dysgenesis affecting directly the stem cell. If it affects the lymphoid progenitor, it can be severe combined immunodeficiency. When it affects the thymus, so that's the George syndrome, and then Wiskott-Aldrich disease, and Behr lymphocyte syndrome, and it affects the lymphocyte or the memory B cells. Right, so for the myeloid progenitor, okay, it can be congenital agranulocytosis affecting the um, source of all the WBCs. Can be CGD. It can be because of the X or the sex chromosome, or right, so or another chromosome, leukocyte adhesion deficiency, or X-linked gamma globulinemia. So this is X chromosome related. Right, so then it can also affect the plasma cell. Okay, common variable hypoglobulinemia, X-linked, hyper IgM syndrome, selective Ig immunoglobulin deficiency. So those are the diseases that may result from primary immunodeficiency, more or less. If the immune system is lacking or deficient in T cells, you will be susceptible to many microorganisms, infection from intracellular bacteria, viruses, parasites, fungi. If you are lacking B cells, you may be susceptible to extracellular bacteria and transmission of antibodies from the placenta or milk. SCID, so this is one specific immunodeficiency, primary immunodeficiency. When there is defective functions of the T and the B cells, this is fatal because no one can protect you. Those cells cannot protect you. So we depend only on the antibodies transmitted from the mother, transferred from the mother. And the T cell receptor genes rearrangement is lacking. Even the myeloid and erythroid components they remain intact. However, it still is a problem. And then agent-induced immunodeficiency. So this is secondary. So as we have been told, can be because of infections like HIV, metabolic disturbance, trauma, corticosteroids. Yes, corticosteroids are used. That's why it's very limited to when we are to use corticosteroids for treatment, we have to limit its use because our immune system will be compromised. Cyclosporin A, radiation, chemotherapy. So that's why people who are undergoing chemotherapy, cancer patients, their immune system is also compromised. So that is secondary or acquired immunodeficiency. And also there is what we call acquired hypogammaglobulinemia. You can see more or less hypo, low, gamma globulin. So that is the antibodies. So the antibodies in the body is very low, immunoglobulins. Okay, so there may be recurrent infections, and of course the treatment here is to supply the necessary immunoglobulins. People who are prone to develop secondary immunodeficiencies are people who have infection, renal failure, protein losing enteropathy, leukemia, lymphoma, myeloma, people who are extremes of age, very old, very young people, and certain drug therapies like chemotherapies. Right, so features, frequency present, and highly suspicious. So if there is chronic infection, recurrent infection, and unusual microbial agents that are affecting the person, incomplete clearing of infection, incomplete response to treatment. So this would um, give the physician a clue that there may be an immunodeficiency. Right, clinical features, moderately suspicious when there is chronic diarrhea, when there's growth failure, recurrent abscesses, so this is infection, and osteomyelitis. And then features associated with specific immunodeficiency disorder, telangiectasia, and partial albinism. Screening test. So there are several tests that can be performed in order to determine if the person is suffering from immunodeficiency. Start with blood counts, CBC, those tests, quantitative immunoglobulin test, antibody response to previous vaccines, So testing for titers, isoglutamine, anti-A and anti-B titers, total hemolytic complement, okay, so complement assay, and infection evaluation like ESR, cultures, and rentgenograms. So testing for the presence of infection. We can also find immunological abnormalities, for example, infection, destruction of the dendritic cells, macrophages, and T helper cells. The T helper cells may decrease in numbers later on, and certain chemokines, cytokines, may be resistant to people with HIV, like CCR5D32, that is a chemokine, cytokine, and certain HLA or MHC types, HLA2 and what else? HLA-B35 are susceptible. Laboratory diagnosis. So this is mainly for HIV. Okay, so because HIV is a kind of infection that is preventable, so the diagnosis of HIV can prevent the spread of the disease, and short course of antiretroviral therapy can decrease the spread from infected mothers to infants. In TB patients, knowledge and therapy for HIV can actually decrease the morbidity. EIA, so that means enzyme immunoassay. This is a general test that can be used to detect antibodies. So they are now fourth generation, so that means it's very sensitive, very specific. There is a solid phase, it can be a particle, it can be the test tube itself, or it can be the micro tube. Right, so this is coated with antigens or peptides or similar antigens with an enzyme, coated with an enzyme, conjugated with an enzyme. It can detect the presence of antibodies, right? So, and this will tell you the time of infection more or less. Antigens are usually a mixture of HIV-1 and HIV-2, group M and O. ELISA, so this is another test. So this is a fourth generation assay, so very sensitive, very specific. It can detect antibodies and antigen. Then we can also check for specific type of cells, T cells. For example, CD4 cell, and we can check if the CD4 cell count is less than 500 per microliter. That indicates that there is immunosuppression. So if the CD4 count is low, that is the time when the person is generally susceptible to second to those opportunistic infections. So the diagnosis of AIDS is when the CD4 count is below 200. The lack of CD4 cells allow for opportunistic infections. I said that. If the percentage of CD4 cell count is less than 14%, you can also say that that is AIDS. We can also do Western blot. This is a confirmatory test for HIV infection. So we detect for specific antibody against a number of different antigens. We can identify. The viral lysate is separated by electrophoresis and determine the specific protein components that are present. And then of course we have PCR, polymerase chain reaction, which we can make use of very small amount of antigen or nucleic acid, which can be detected by nucleic acid probes. Right, so that is the end of this presentation. Thank you very much. I hope you learned something. It's a very long video, but please try to digest every single information. I will also be providing you with handout, printed handout for you to utilize. Thank you.